With this, I think now we open for the discussion. There are already good 6 speakers in this subject. Any questions, please?
Yes, sir.
Dr. Jamshed, this is Dr. Manoria. What is the magnitude of benefit of GLP-1 in primary prevention? Your comments on primary benefit, the magnitude of benefit.
I'm almost certain that there is benefit in primary prevention as well, because they're basically drugs which are reducing atherosclerosis. So rather than using it in patients who have full-fledged coronary artery disease, bypass, post-plasty, I think they should be used early in patients with diabetes. And I think unlike SGLT2, where the benefit is more after heart failure is developed, I think these drugs would benefit diabetic patients before they develop serious coronary problems. So I think they have a good role in primary prevention as well.
Dr. Dalal, you just showed and shown in trials that liraglutide GLP-1 RS trials, it stabilizes the plaque. It is just a trials finding, or what is the exact mechanism of action, how it stabilizes the plaque, liraglutide?
Any diabetologist has the answer. I'm sorry, I don't have the answer to the exact mechanism of plaque stabilization. A couple of
Dr. Anil Boraskar, Dr. Mangesh Tiwaskar, they are there. Any exact mechanism of action? How it stabilizes the plaque?
Yeah. So, Boraskar sir, you need to unmute yourself. Yeah.
Yeah. Tell me, what is the question?
How do you stabilize the plaque with the GLP-1? What is the exact mechanism?
Exact mechanism. For example, liraglutide you are giving. How it stabilizes the plaque? What is just a trial finding, or it is the exact mechanism of action?
The exact mechanism, how it stabilizes the plaque,
yes,
is a great matter of discussion, because the plaque stabilization is usually done when the environment is changing. Now, first stage to do anything is to prevent oxidative stress. Now, oxygen-free radical is a major cause of either dislodging the plaque or increasing the size of the plaque. Now, oxygen-free radicals attack is the major objective of both cardiologists and diabetologists. And therefore, I've been talking about free radicals since last 30 years. And the major crux in my therapy is a change of omega-6 fatty acid and omega-3 fatty acid ratio that prevents the oxidation-free radical and prevents the dislodging of the plaques or even microembolization. So the practical aspect is to stabilize the plaque with, of course, statins, sometimes large dose statins, aspirin, and of course, a good omega-6 to omega-3 fatty acid composition less than 5, and that is seen in our traditional cooking oil of coconut and ghee, and many people took objection to this. Till today, the world is talking about the virtues of coconut oil and ghee. The cardiologists always opposed us. What nonsense you are talking. Now today, people have realized that the so-called heart-friendly oils of high omega-6 ratio are actually detrimental, and one should minimize their use in dietary cooking so as to prevent free radical damage to this plaque. I can only talk on this because I have a lot of data actually on stabilization of plaques and atherosclerosis and prevention of atherosclerosis, but I think I will briefly touch it when I'm talking about prandial regulation.
Dr. Dalal, Dr. Manoria, Dr. Dalal or to Dr. Pandey. Pandey is there. Dr. Dalal, then the Emperor Preserved slowed down the declining EGFR in the Emperor Preserved, but the renal benefits were not concordantly seen. Any specific reason for this?
I think when you talk of heart failure with preserved ejection fraction, the contributory factors to preserved ejection fraction are multitude factors. It's not as simple as reduced ejection fraction. And I think, therefore, the benefit of a particular drug in reduced ejection fraction will be quite different from what we see with SGLT2. In terms of your specific question about why the benefit was more seen in certain trials with renal dysfunction, etc., have you seen that in number of trials that some trials show more benefit, some show less? For again, if you look at the Emperor Preserved trial, the Emperor Reduced trial, it showed no significant benefit in terms of cardiovascular mortality, which the Emperor Reg had shown. So I think little differences that you see out there, I don't know whether they're related to different patient groups, etc.
No,
So
but the issue is the issue is the EGFR showed favorable effect, but despite this, the benefit was not seen.
Right.
I have a question to all the cardiologists, Jamshed. We remember we did 2 months back along with Mangesh the workshop on the free radicals. Remember, Dr. Jamshed?
Yes.
I have to ask one question to all of you. Is regarding is there a division of benefit mediated through cardiovascular risk factors or cardiometabolic risk factors and through the atherosclerotic cardiovascular disease? Because early on we had a differential differential benefit from SGLT2 vis-a-vis GLP-1. That will answer many of the questions. What the cardiologists feel today, that both the GLP-1, SGLT2 benefit either cardiometabolic risk or atherosclerotic cardiovascular disease. Of course, they're linked, but any new thoughts on that?
I think the general practical aspects of this are that if you have atherosclerotic vascular disease, then you go for GLP-1. Early diabetic treatment should go for GLP-1. Compared to that, the SGLT2 are not so much beneficial in pure atherosclerotic disease, but the benefit is seen much more once the ejection fraction drops, except, of course, in the most recent preserved Emperor trial. But according to across the board, it's more beneficial for heart failure with reduced ejection fraction. So if a person has normal ejection fraction, completely normal ejection fraction, and diabetes, I would use GLP-1 agonist rather than SGLT2.
I think that is the answer. And we also published a paper, Mangesh and me, regarding the vascular euphoria of the SGLT2 inhibitors. And it was centered around exactly the point you are making here. Thank you.
Yeah, absolutely. And sir, one more point that I wanted to, as Dr. Boroskar has talked about, hardly we have discussed, many times we only concentrate on the glycemic benefits and related, cardiovascular outcomes, but we hardly talk about the plaque stabilization through either prevention of lipolysis, which happens at the plaque level. Also the inhibition of, the ectopic deposition of the fat. It's, the newer lipid synthesis also is very, very one of the important points and happening, and especially liraglutide has been proved to have this, and this could be one of the reasons why, because these are all lipophilic drugs, so they will definitely, pierce the plaque. It also has got an effect on the HMG CoAs reductase, which is also responsible for, stopping of this local lipid synthesis. Also, it will improve the HDL scavenging from the plaque.
I think we have so many studies with statins and PCSK9 looking at intravascular ultrasound, etc., looking at plaque quality, etc. But we don't have those studies with GLP-1 or with SGLT2.
Yes.
And I think more accurate studies need to be done. The statement of plaque stabilization is more a general thing without actually defining the particular benefit like we got with statins and PCSK9.
And as Dr. Mahapatra was talking about, in fact, if you really look at the Emperor Preserved, it was not powered to look at actually the renal outcomes. They were all secondary outcomes which came out of the cumulative analysis. So probably we deep dive into those data, probably we'll definitely come out with some benefits. Because as Dr. Dalal has spoken, beautiful concept of pump pipes and filters. And if at all it works, it has to give you benefit. Probably just that you need to change your look, approach to the entire data analysis.
Sir, my question is...
Tivaskar, sir?
Yes, sir.
Sir, beautiful expression regarding that, and I like your way of presentation. I just to add on, sir, my query.
1 minute left, sir.
Whether MR spectroscopy related studies with GLP or RNA regarding lipid molecule, that there is increase in size and there decrease in HDL level, that can be a postulate for that plaque.
Absolutely, that is what I was talking about. Absolutely, that is what exactly I was trying to figure out. Is this that we always have entertained the whole thing as a glycemia perspective and interpretation. We hardly look at these benefits because we always keep on looking at the numerical value changes, but the cellular or tissue value changes. Dr. Jha, I'll be finishing in a minute.
Yes. Last question from Dr. Das sir. What is the maximum dose of glimepiride to get the maximum benefits?
the maximum dose prescribed is 8 milligram, but we get benefit at 4 milligram. We need not go to 8 milligram.
Okay. Thank you, sir. Thank you.
I think with this we end this session, wonderful session. I thank all the speakers and the participants. And at the same time, I also thank PC Manoria and Mahapatra for inviting us to chair the session. But one request,
Thank
there
you.
should be a lunch session, even if it is a webinar, there should be a lunch session at least for people like us.
So
Thank
Dr.
you very much.
Mahapatra, sir, Dr.
Okay,
Mahapatra
thank
has
you.
already assured you that,
Yeah,
there
I've
will be a lunch
assured
which will be delivered to
Thank
you.
you.
Don't worry, sir.
Thank you, Chairperson Dr. Modi, Dr. Jha, Dr. Parasar, Dr. Amitabh Sur, and all the eminent speakers. It was really a wonderful session.